So we're really excited for all of you to be here. My name is Dr. Jamie Fur. I'm the president of the Selective Mutism Association. This webinar is brought to you by the Selective Mutism Association, as well as made possible by a generous grant from the Gordon and Marilyn Macklin Foundation. This webinar is being recorded and will be available on the Selective Mutism Association's YouTube channel within 24 to 48 hours. A link to the recording will also be sent to you directly to every registrant early next week. Please also feel free to send in questions. You should have a question box. You can send those in, and we're going to leave about the last 20 to 25 minutes for questions and at the end of the talk today. Whatever questions we don't get to, though, we will be sending on to Dr. Sanchez, and she'll get back to you over the next several weeks with any answers that we weren't able to get to. We will also be providing a PDF of her slides in the email, and she will be providing her email address at the end of the presentation. So I am very excited because I really, I know Dr. Sanchez well, so I'm very excited to get to introduce Dr. Amanda Sanchez, who earned her PhD in clinical psychology at Florida International University, where I am. Yay. So she focused on accessibility of mental health treatments for underserved families and youth. Her main research interest focuses on the accessibility of quality mental health care for traditionally underserved families. More specifically, the innovative delivery of mental health services in children's natural environments, understanding structural and perceptual barriers to care, and improving the cultural responsivity of mental health services. As a graduate student, she led an NIH-funded project examining the use of the Cultural Formulation Interview as a strategy to improve satisfaction, engagement, and clinical outcomes in traditionally underserved children receiving mental health care services for behavior problems. She's now a postdoctoral fellow at the University of Pennsylvania Perelman School of Medicine, continuing to work on research to improve dissemination and implementation of effective treatments to underserved youth. So we're really looking forward to your talk today. Dr. Sanchez, I'll turn it over to you.
Thank you so much, everyone, for being here today. I'm really excited to share some of my work with you all, as well as just some general guidance and thoughts around how to improve the cultural responsiveness of our services, and particularly through the use of the Cultural Formulation Interview. And then I'll talk specifically about some examples related to selective mutism, and I think the question and answer period will be really useful to talk through some specific examples and hear any questions or thoughts that you all have. I also wanted to introduce myself, and so my name is Amanda Sanchez. I identify as a cisgender female from a Latina and white background. A first-generation college student, now recently with a PhD from Florida International University. So the goals for today are to give a little bit of background around why we need culturally responsive services, then to think a little bit about the clinician's role and the use of cultural humility. And the majority of the time will be spent going through the Cultural Formulation Interview, both the core Cultural Formulation Interview as well as the child and adolescent Cultural Formulation Interview. And then we'll discuss a little bit about the implementation of the CFI, how we might incorporate a tool like this into our clinical work and practices. And then, of course, some time at the end for some questions and discussion. So why do we need culturally responsive services? As many of you probably know, we have a lot of disparities in regards to access and utilization of mental health care. So people from marginalized backgrounds, oftentimes people of color, people from low income backgrounds, are less likely to seek and engage in mental health services, and they're receiving fewer and poorer quality of services when they do engage. And thinking a little more specifically around anxiety disorders, there's a real lack of clinical research that is focused on youth of color. So there's a lower rate of inclusion in treatment studies, so to understand how well our treatments work. And there's also lower rates of treatment engagement. So there are less, youth of color are less likely, again, to engage in and benefit from our evidence-based treatments for anxiety. Although epidemiological studies show that there are similar rates of anxiety in different racial and ethnic backgrounds. So despite similar rates, they're less likely to access and benefit from care. And thinking about selective mutism specifically, again, a real lack of understanding and research around selective mutism in youth of color, but there is some research and some evidence that immigrants and bilingual children are more often diagnosed with selective mutism. And there's some different possibilities here. One study found that acculturation level may affect children's development of selective mutism. So when families or their caregivers are less acculturated, meaning that they are less familiar with and kind of ascribe less to American ideals or norms, that their children are more likely to be diagnosed with selective mutism than when they are more acculturated to American norms and beliefs. And this kind of difference in acculturation levels between parents and their children, oftentimes talked about as acculturative stress, this can be really difficult for families to navigate these multiple cultural contexts and also multiple different beliefs within a family and different levels of acculturation within a family. And these are factors that can potentially influence, as you may imagine, a child's comfort level in kind of speaking a new language, but also speaking in new contexts. And this is something that I know you all will be learning more about. There's going to be some panels on thinking about bilingual communication and reference to selective mutism, but that's one piece to consider. Additionally, there are a lot of barriers that especially youth of color face in regards to accessing and engaging in mental health services. So some of the main ones that we know are kind of logistical barriers like cost, accessibility in terms of language, location of mental health services, whether they're provided through public insurance or whether they're just private pay. All of these factors affect youth's ability to access these services, but also we think about other types of barriers that even when we take into account socioeconomic status, people are still facing other types of more perceptual barriers, such as trust, stigma, so discomfort around going and seeking mental health treatment, not wanting others to know about it, feeling like they should be able to handle mental health difficulties on their own, differing beliefs about causes of the mental health problem or difficulty, so differing from the family and the therapist having differing beliefs, as well as feeling misunderstood. These are all factors that have been found to be related to poorer engagement among youth of color. And one thing that's important to point out is a lot of these barriers exist because of historical mistreatment of people of color in our healthcare and mental health care systems. For example, trust or lack of trust of providers due to kind of a history of mistreatment in mental health care studies and healthcare more broadly. So it's important to understand why these barriers exist. And one thing that's been much more kind of present and much more readily talked about is the idea of systemic racism and how the way that our systems have been developed can really privilege certain groups of people, especially white families. So in understanding how our systems have kind of been developed both broadly and our mental health system to kind of favor one group of people, this is important to help us understand that these barriers are not because the person is from a different cultural background. It's not kind of their problem or their fault. It's how do we understand how our mental health treatments are developed and implemented in ways that can actually create some of these barriers, and then what can we do to address them to make those services, again, more culturally responsive. So thinking about this kind of systemic issue and our evidence-based treatments have been developed in white communities by white researchers. So by this, I mean they've been tested primarily with samples of middle-income white families. And because of this, evidence-based treatments often don't take into consideration cultural or contextual factors that may be very important to a family's ability to engage in and benefit from treatment. There's also very limited guidance for therapists on how to assess for and incorporate cultural information into both their conceptualization of treatment as well as continued treatment implementation. And this can lead to some of those barriers I discussed previously in terms of having non-agreed upon goals. So oftentimes more therapist-directed goals rather than goals that directly reflect the family's perspective and ideals. Patient feeling misunderstood, having lower levels of trust, and then also lower therapeutic alliance. These are all factors found to, again, affect the quality of services received by youth of color. So now I want to talk a little bit about how we respond to these issues and how we think about improving the cultural responsiveness of our treatment. So first, I wanted to give just kind of a brief definition of what I mean when I talk about culture. So culture includes, but is not limited to, the values, orientations, knowledge, and practices that individuals derive from membership in diverse social groups. For example, ethnic groups, faith communities, occupational groups. One thing to be aware of here is this is not only due to nationality or racial or ethnic background, but this can be other types of groups that people belong to, as well as faith communities, occupational groups, neighborhoods, even sports groups, anything that really affects the values and knowledge and practices that one holds. Additionally, culture refers to aspects of an individual's background, developmental experiences, and current social context that may affect his or her perspectives or coping. For example, discrimination, issues with immigration, socioeconomic status, other factors that are affected by one's background, and also in terms of their experiences, not just background in terms of their groups they belong to. And then we think about culture also in the way that there is an influence that family, friends, and other members of one's social network can have on an individual's experiences and beliefs. So in multicultural counseling, the therapist is someone who is constantly aware of his or her own cultural bias, understands the different beliefs and values of his or her clients, and engages in training to develop and foster skills to work with culturally diverse clients. So while the majority of this presentation is going to be focused on how to understand our families and provide more culturally responsive care, one important piece that I didn't want to leave out completely is that the therapist also plays a large role here in regards to their openness and willingness to evaluate themselves and understand their own cultural background and how that may or may not relate to their client, and also the work that they're doing with their client. So along these lines, in order for a therapist to be able to provide culturally responsive treatment, it's really important that they practice cultural humility. And cultural humility is different than what we think about in terms of cultural competency in that it's something that is practiced and never kind of reached. You never reach cultural humility. It's a practice that you have, and there are three main components of that practice. The first being having an open and aware mindset, or kind of a curiosity of learning and understanding the experiences and perceptions of the family that you're working with, of their background, because kind of no matter what, even if we look similar to our patient, we're going to have had different experiences that influence the way that we think about the world. So really being open and aware that we are different, and those differences are valuable and important to understand. The second component is commitment to self-evaluation or critique. And this is really understanding your own role of cultural meanings and biases that you hold as an individual, as well as your place of privilege or power, especially in the clinical encounter. So what aspects of your background kind of give you some of that power or privilege in the room, and how can you acknowledge that or address that? For example, education level, race, socioeconomic status, even just your position in the room as a therapist, as someone to kind of give knowledge or give those skills. And thinking about this last step of then how to change that. Once you have this awareness of both yourself and your patient, how do you then act toward fixing these power imbalances in the client-therapist dynamic? And part of this, what we'll talk about soon, is using strategies, getting training, using strategies such as the Cultural Formulation Interview. It's not by any means the only one, but to really gain awareness and improve the services that you're delivering to all families, and especially those from marginalized backgrounds. So because of these disparities in care, there's been a lot more attention in research and clinical work around how to improve cultural responsiveness of our treatments. And one main way that this has been addressed in research is by adapting our evidence-based treatments for particular cultural backgrounds. And in doing this, researchers are developing kind of treatments that are more responsive, in that they take into account language, beliefs, specific idioms, or cultural examples that may be more relevant to a particular cultural group. And this has been found to be useful in improving engagement and outcomes in certain situations. However, the idea of adapting each kind of evidence-based treatment, that again, the evidence is based on a very particular group, but of adapting each evidence-based treatment can be very resource intensive and may actually over-apply cultural values by saying that because you're from a particular racial or ethnic background, that you ascribe to the same beliefs as others and that same racial ethnic background may not actually be true. There's a lot of diversity within groups, of course, and because of this, there's now more of a push to really adapt or tailor treatment for each individual client, taking into account issues that are particularly relevant to their cultural background, but not assuming that they ascribe to certain beliefs or values, but rather asking and learning about the individual client. So patient-centered assessment of cultural factors, again, asking the questions to really understand that individual patient, how their identity and background influences their beliefs or not, and how that influences their understanding of mental health and help seeking, can be really helpful in understanding that broader context of presenting problems from the patient's perspective, understanding their cultural background, barriers that they have experienced and may continue to experience in terms of accessing mental health treatment, as well as their cultural strengths, things that have really been helpful for them in the past, and what may continue to be helpful for them moving forward that you could incorporate into treatment. By using cultural conceptualization, we move away from the dominant individualistic assumptions in which behaviors are understood independently of cultural context. If cultural contexts are not examined within the psychotherapeutic process, we cannot question them. As a result, we end up supporting dominant and often oppressive power structures. This is a quote by Dr. Martine LaRoche, and I really like this because it really makes us realize and think about the fact that by not asking these questions, by not considering how our family's background and culture may influence the way that they think about things, influence their perceptions and needs for treatment, then we are kind of keeping that structure, that power dynamic of kind of we know what's best, and we're basing it off of work that was done in primarily white populations, assuming that none of this matters, that their perceptions and their background doesn't matter. So it's important to just think about and recognize when kind of considering whether to assess and incorporate cultural factors into treatment. So now I'm going to share a little bit about the cultural formulation interview specifically. So just as a reminder, this is one tool. It's the tool with the most research at the moment, but there are others. I'm going to share briefly another with you as well. But the cultural formulation interview was developed to be a kind of feasible, useful tool for clinicians to use when assessing for cultural factors in an intake session. So it's a brief 16-item tool that's semi-structured, so it provides guides and specific questions to be asked, but there's no expectation that the questions are going to be asked in that specific way. It's kind of a guide for clinicians to use rather than a strict structured assessment. So the CFI assesses the patients and members of their social networks' perspectives of the symptom experience, their views of mental health and help seeking. So the idea is that you're asking all questions in the CFI, and that's kind of how it's developed, but there's encouraged flexibility based on what you're noticing around your client's needs and the setting in which you're delivering the CFI. I'm going to touch on this later, but there's also supplemental guides. If there's more questions you want to ask about a certain area, there are guides to kind of go deeper into specific content areas. So the CFI was developed to be used as an initial assessment paired with a diagnostic assessment. So this does not in any way replace doing a diagnostic assessment. It's to be used alongside of it. And using the CFI highlights the centrality of the patient's perspective, because all of these questions you're asking the way that the patient or the caregiver sees what's going on with them or their child. And it allows this perspective to then guide the rest of the interview. So it was initially designed to be used prior to a diagnostic assessment so that you could get really important cultural contextual factors and then kind of include that throughout the diagnostic intake. It also shows that the patient shows the value that you're kind of placing on their views by really focusing on that and then carrying it through the rest of the intake and treatment planning as well. And the CFI was developed to support engagement, diagnostic accuracy, and shared decision making. So once you really understand the patient's perspective, you're able to also integrate this within your treatment planning. And it reduces those power dynamics by, again, really placing the importance of the client's view and their perspectives. Another important piece of the CFI is that it's in the DSM-5. So it's very accessible. You can just Google cultural formulation interview and it pops up with the PDF. So it's a very accessible tool as well. In terms of research support for the CFI, initial research has mostly been done in adult populations, and the CFI has found to be feasible and acceptable by clinicians, and also has been shown to improve medical communication, rapport with therapists, and overall patient satisfaction. So there hasn't been as much work done in really understanding how it can influence treatment outcomes, such as engagement or treatment effects. However, I'm going to share with you a little bit about the study that I did that looked at improving engagement through cultural assessment. So I worked with a community organization in Miami that was providing parent training services in 3 different underserved communities in Miami. There were 89 families randomly assigned to receive either the cultural formulation interview plus their standard intake procedures or just their standard intake procedures. The families were overall from racial ethnic minority backgrounds, about 90%, the majority Latinx, and also about 20% Black or African American families. And over half of families were from low income or extreme poverty backgrounds. So I'm just going to share some of the main findings. If anyone has any particular questions about this project, I'm happy to go into more detail, but I thought I'd just share a couple main findings and important pieces from this project. So we found also that therapists found this feasible and acceptable. They liked using it. Patients reported feeling more understood by their clinician when they received the CFI rather than their standard intake. Therapists also were more satisfied overall with their intake when they delivered the CFI versus just their standard intake. And there was also improved engagement. So families were more likely to complete their first phase of treatment. So the parent training was broken down into 2 phases, and they were more likely to complete that first treatment or that first phase. And then for families receiving services in Spanish, they were actually more likely to complete and benefit from services. They were more likely to complete the full course. And in this parent training program, if you completed the full course, that also meant that the behavioral challenges were lessened as well. So there were some stronger effects for families receiving services in Spanish. We weren't able to fully understand why that was in this study, but it's something we're interested in figuring out and learning how this can better support therapists in improving their cultural responsivity. So just an overview of that this is kind of preliminary research in child populations, the feasibility, acceptability, as well as preliminary effectiveness of engagement and treatment response. And then it's recommended for the caregiver. So in this study, caregivers were asked these questions. They were given the cultural formulation interview as the children were young. Although kids could still answer some of the questions, most likely this was really targeted to the caregiver who's actually bringing the youth into services, and for young kids are often very involved in treatment. However, with all the research that's been done, there is not yet a lot of guidance on how and when to integrate the cultural formulation interview into treatment planning. So that's something we'll talk a little bit about today as well. So now I'm going to go into talking and showing you more specifically what the CFI looks like and the different domains. So there are 4 main domains of the cultural formulation interview. The first is the cultural definition of the problem. So things like how would you describe this problem to your family or others in your community? It's really understanding the family's perspective of what's going on with them, and also how they would explain it to someone else, to kind of take it out of that more clinical space, and how would you explain it to someone within your family or in your community. Cultural perceptions of cause, context, and support. So questions such as, what do you think led to this problem? And what's the most important aspect of your background or identity? How does this influence the problem that you're dealing with? Then the third domain is cultural factors affecting self-coping and past help seeking. So how their community members think they should receive help, how they've received help in the past, what was helpful, what wasn't. And when we talk about receiving help here, I'll go more into this, but it's not specifically just about services they've received in the past. And then the last domain is cultural factors affecting current help seeking. So what the family wants out of therapy, problems they've had in the past due to misunderstandings they've had with providers or with clinics. So now I'm going to go into the actual questions of the CFI. This is an image of the part of the first page. And one thing that I think is important here is that's kind of circled in gray is a reminder to use the term, expression, or brief description elicited in the first question to identify the problem and subsequent questions. So this is kind of a basic clinical skill that we often learn, the reflecting what someone else says. Oftentimes when we're talking about a problem that a child is dealing with, we use the language that we've learned, the clinical language. However, it can be really important to show the family that you're understanding them by using the language that they use to describe the problem. And I will go into more detail with that as well. This also shows the introduction where you're kind of introducing why you're asking these questions. So the example here is, I would like to understand the problems that bring you here so that I can help you more effectively. I want to know about your experiences and ideas. I'll ask some questions about what is going on and how you were dealing with it. And then remember, there are no right or wrong answers. So another piece that I typically add here is to bring up differences between yourself and the family, or to acknowledge that they may exist. Something potentially like you and I have had different experiences and may understand things differently. So I'd like to understand your experiences and ideas. So just adding in that you acknowledge that your experiences are different in the way that you see the world. And I think that's a good place to start that conversation, definitely not an ending point. So here's the first domain, cultural definition of the problem. So the first question is, what brings you in today? And this is very typical question. Most of our assessments have them in one way or another. But then there's this prompt of, people often understand their problems in their own way, which may be similar to or different from how doctors describe their problem. So how would you describe your problem? And this is giving families kind of that opportunity to describe things in their own words. And then just a reminder to use their term for the remainder of the assessment. Then for the second question, sometimes people have different ways of describing their problem to their family, friends, or others in their community. How would you describe your problem to them? So this is, again, getting the family kind of out of that clinical context. How would they talk about this in their community? This also can help you understand a little bit about the context with their family or community. Some families will say, I never talk about this with anyone else. I wouldn't tell anyone else about this. Or some might say that, you know, my mom thinks that I'm doing something wrong. Like I should just be making her talk. I'm doing something wrong. So you can start to understand these different dynamics also within families and communities that could be influencing the way that this problem is occurring. And then, what troubles you most about your problem? This is a really, really important question that I think we don't necessarily often ask. And this can help us really think about what those treatment targets will be. So for kiddos with SM, a lot of times, you know, the general goals, of course, are helping kids to speak in different settings. But it may be that what troubles the caregiver or the patient most about their difficulty is something else. It may be their difficulty connecting with a certain caregiver, or their loneliness because they aren't able to talk with another child or peer. So by being able to understand what they think troubles them most or what's worse about it, we're able to then kind of use that in that motivation and target for treatment as well. So the second domain is cultural perceptions of cause, context, and support. So why do you think this problem is happening to you? What do you think are the causes of your problem? And again, these are prompts, but you don't have to ask these questions in this specific way. I know some therapists have found that, you know, why do you think this is happening to you felt a little too jarring for them. So just asking, what do you think is causing this, or what do you think led to your problem, was an easier, more comfortable way of saying that. And these questions are really important because we can sometimes find out other beliefs that families may have in regard to, again, why something is happening. And it may not be the way that we understand what might cause or maintain difficulties such as anxiety or selective mutism, but it's important that we understand the family's perception of cause, and that then we're able to incorporate that information into when we do kind of psychoeducation, acknowledging that their beliefs may be somewhat different than other information that we have. Then what do others in your family, your friends, or others in your community think is causing your problem? So again, this is a space where there oftentimes something comes up around what other family members think they should be doing that they're not, or places again where families are not sharing this type of information with one another, or not comfortable doing so. And just a reminder that I talked about using this with caregivers. This can also be used with teenagers and kids who may have a little more awareness or ability to answer some of these more challenging questions. Of course, with kiddos with SM, you're not going to be asking them lots of these types of questions, probably for a while. And there are other ways that we can think about engaging them in these types of conversations even before they're ready to do it verbally. Then we have stressors and supports. Are there any kinds of supports that make your problem better, such as support from family, friends, or others? And are there any kinds of stresses that make your problem worse, such as difficulty with money or family problems? So this is a place, and on the kind of side of this assessment, there are other kind of follow-up prompts of additional questions you could ask if families aren't responding to this. So here, understanding the supports can be really helpful in determining maybe who's involved in treatment, or what aspects, what coping skills the family already has that you want to incorporate and make sure they're continuing to use. Additionally, it's really important to understand the kinds of stressors that the family is going through. And this is a place where the additional prompts can be really helpful. So if you know a family might be struggling with any kind of issues with money, with access to safe environments, safe places to exercise, to be outside, healthy foods, this is a place to kind of ask about those things too. Such difficulties such as money, food insecurity, difficulty with traveling, getting to places you need to be. So these are This may come up in barriers as well, but this is a place to really understand that context in which the family is living and how these factors may potentially get in the way in treatment and how you could help support the family more fully. The second domain is cultural perceptions of cause, context, and support. So this is a piece that can get a little bit tricky and seems to be a bit more challenging for clinicians to ask about. I'd love to hear people's thoughts if they have any as well. So this is a section where you're talking about cultural identity and then asking about it. So the prompt here is, sometimes aspects of people's background or identity make their problem better or worse. By background or identity, I mean, for example, the communities you belong to, the languages you speak, where you or your family are from, your race or ethnic background, your gender or sexual orientation, or your faith or religion. For you, what are the most important aspects of your background or identity? So one thing that has come up is that when using this with people who don't necessarily think about their background or identity or have difficulty answering, therapists can sometimes get a little bit stuck. And I think one important thing to remember here is, again, that everyone has a culture or identity, and that this can be expanded a bit to what are the things that you value, what's important to you. And oftentimes I add family if I know they're part of any groups in terms of church groups or sports groups, especially with teens. Being a part of a sports group and being within that can be their own kind of cultural context. And this is a place where you can give those extra probes, especially when a family is maybe having a little more difficulty answering that question. That it doesn't mean that they have nothing to share. It might mean that they're not used to talking about these sorts of things, and that it could be helpful to add some additional probes of, you know, some families have told me that their family and that relationship is really invaluable to them, or their involvement in this type of group, whatever it is. And then the next piece is to understand if there are any aspects of your background or identity that make a problem, that make a difference to your problem, and any aspects of your background or identity that are causing other concerns or difficulties for you. And this is where things like immigration, racial discrimination can come up. And I think it's important to actually probe for those things. If you're working with a youth of color, a family of color, that you're probing for and showing that you're willing to talk about some of these other difficulties as well. Of course, issues with immigration can be really sensitive and tricky. So you want to put it in the position of, I want to understand kind of the stresses you're going through so that I can best support you, and that you're not there to kind of share any of their information with anyone else, especially in regards to immigration or issues around that. Also, sometimes what comes up here is if a family is from a different country, potentially. I've worked with multiple families who are then able to bring up here like, oh, it's really difficult for me because I think differently. I see the world differently than people here do. And this is a place to be able to understand those aspects as well of cultural background, how it can create some difficulties. These are also areas where if you're doing this with the child and caregiver, you're able to really understand maybe differences between the caregiver and the child. And again, child with selective mutism, we probably wouldn't be doing this right away unless they're comfortable talking with the clinician. The third domain is then cultural factors affecting coping and past help seeking. Okay. Sometimes people have various ways of dealing with their problems. What have you done on your own to cope. And then an important part here that we don't typically ask is often people look for help from many different sources, including different kinds of doctors, helpers, or healers. In the past, what kind of treatment, help, advice, or healing have you sought? So this is a place where we can really understand if there's other areas in the family's life where they have sought help and it's been useful to them, or maybe it hasn't. Maybe it's expected that they talk to their pastor or that they talk with someone in their community, but it hasn't been helpful. Or maybe it has, in which case that may be something to consider incorporating within the treatment plan. So this is another place where we can probe for potential barriers that families have experienced in regards to the mental health care system. So has anything prevented you from getting the help you need? So this might be kind of structural barriers, again, like difficulties with transportation or money, but it also could be things like stigma, discrimination, or lack of services that understand your language. And these are prompts that are important to give so that families feel like they can actually have those conversations and talk about these things, remembering that kind of power dynamic of you being in that situation, the person in charge, but how can you kind of lessen that a little bit and help families feel comfortable being able to share the experiences that they've had. The fourth domain, cultural factors affecting current help seeking. What kinds of help do you think would be most useful for you at this time? And then what are other kinds of help that your family, friends, or other people have suggested would be helpful for you? So this can allow you to kind of clarify expectations, so really understanding what the family is looking for, making sure that's something you feel like you can provide. And this is another place where you're able to understand maybe differences between the family and their social network, or similarities in that maybe they have family or friends who have suggested they get help in the way that they are, or suggesting something completely different. And that's important for you to know as well, if there are going to maybe be things that are conflicting with the treatment that you're giving, or if there are aspects that you could potentially incorporate. And lastly, the fourth domain, the last portion, clinician-patient relationship. The probe here is sometimes doctors and patients misunderstand each other because they come from different backgrounds or have different expectations. Have you been concerned about this, and is there anything that we can do to provide you with the care that you need? So this is where, again, you can elicit potential issues around racism, language barriers, cultural differences that influence communication. And there are definitely times where families won't answer this question. Either they're not sure or they don't feel comfortable. And you asking this question and putting it out there lets them know that it's okay to do that. It could take time for people to feel comfortable answering questions like that, but I found this to be a really useful question. And in my study as well, the therapist reported that it's a question that often helped families to really open up about their past experiences. I've had lots of families tell me that they just felt really misunderstood. They felt like they were bad parents because of how they were treated in previous situations. And this can really help to start to build that trust, to show that you're open to having conversations if things don't, if issues ever come up in treatment. So that was the core version of the CFI that can be done with caregivers or youth. I often kind of combine it and will ask caregivers the question about themselves and their youth. If they feel like they know they could answer that question for their child, I might ask that, especially in regards to kind of stressors or coping that they might have, or things that they think are causing what's going on with them. With younger kids, I'll just use this as a caregiver report purely. And now I want to share with you some supplemental modules. So these are, I have a list of them here. This is also something you can Google and look up if you're interested in learning more. So these are additional modules that you can use that provide just kind of deeper assessment into some of these areas. One that I'm going to share with you is the supplement for school-aged children and adolescents. So the school-aged supplement allows you to identify the role of age-related cultural expectations and possible cultural divergences between school, home, and the peer group. So I'll explain that a bit more in a moment. And then whether any of these issues in terms of different expectations they may be having impact the problem that they're dealing with. And then some children may not be able to answer all questions, so it's important to kind of select and adapt questions to ensure they're developmentally appropriate. And again, kids with SM, you may not be asking this right away. You may be incorporating it into play or other types of activities. So this is the interview. It's shorter for a bit shorter for the school-aged youth. Asks about feelings of age appropriateness in different settings. So basically, what that means is, do you feel like do you feel like you are like other children your age? This is the first question. In what way? Do you feel like you're different? Does this feeling of being different happen more at home, at school, and other settings? So you're trying to understand their experiences in different settings, and this can sometimes speak to that kind of acculturation piece. Also can be very relevant for families that are from the US as well, that their parents maybe have different expectations than teachers, than friends. And then questions about, do you feel your family is different from other families? And then you can kind of follow up about that, how they're different. Do you use different languages? In what situations do you use different languages? And some other questions about kind of what's special about you. Are there any special meanings to your name? So understanding any potential cultural factors that may be important. And then asking about stressors and supports, both at home, school, and with friends. So in different types of situations, you may add in different ones if you know the child is kind of engaged in different types of situations. And then you're asking about expectations. What expectations do your caregivers have for you? What expectations are there at school? And what about from your friends, from other kids? What are expectations, and maybe how you're meeting them or not? So this is, again, much more than we may typically ask from a kid to really understand their perspective, how they see themselves in the world compared to other kids and in different settings. There's an additional component for adolescents that ask more about kind of their coming of age. Are there any important celebrations or events in your community to recognize reaching a certain age or growing up? What it's like to be an adult when you're considered to be an adult. So these are more kind of the coming of age type questions. Is there something a special way or a specific way that you understand that in your community? And also, like, then what are your responsibilities in becoming an adult? So doing the either the supplement or the cultural formulation interview, both possible with kind of older kids and adolescents. I like using the core CFI with adolescents. I think they can understand it, and it's helpful to get that information from both the parent and the adolescent's perspective. With younger kids, I think the supplement can be really useful and can be done in play or in less difficult situations than just kind of interviewing them. I also wanted to share that there's another child cultural interview called the Jones Intentional Multicultural Interview Schedule. And this one, what I like about it is that it asks more specific questions about race to children, rather than just kind of asking how you're similar, how you're different. It asks more specifically how you identify and how does that influence your relationship with other people. And this is also a kind of plug to incorporate other questions that seem important. It doesn't have to be just this kind of structured way of assessing, but making sure to really include questions that you think are getting at your client's experiences. So now I wanted to think a little bit about how we then incorporate this information into case conceptualization and treatment planning. So I think it's really important to take the information from the CFI or from whatever kind of assessment that you're doing and making sure you're thinking through the different steps of a case conceptualization. What are the treatment targets, the strategies that are going to be used, maintaining and causal factors, and how these can be very different from the kind of clinical perspective and from the family's perspective. So again, treatment targets might not necessarily just be related to speaking for kids with selective mutism, but maybe more about different relationship building with different people and their family, or being able to go to a certain meeting at their church, or something that's kind of more specific to their own kind of values and perspectives. And it's important to make sure that those are included as the specific treatment goals. Maintaining factors as well. There's a lot that comes up in the CFI that can help to understand maintaining factors, especially around different family dynamics and beliefs that families have, as well as, again, the causal factors piece, what we think is kind of causing that versus what the family thinks, and how to incorporate both in that initial case conceptualization. Also want to think about the content and process. So the content of our services can also be shifted a little bit to incorporate factors that we're learning from cultural assessment. So things like psychoeducation. When we give our typical psychoeducation around the development and maintenance of anxiety, we can also include those specific factors that families have shared around both their beliefs about maybe the causes of anxiety, how it's maintained. Also, if there are any other specific factors around kind of family dynamics that are maybe maintaining that anxiety in different situations. And that can be included within that psychoeducation as well, to have a fuller picture of what's going on. Additionally, to include engagement strategies, so we're able to assess what barriers may come up, whether it be barriers like logistical ones or barriers around trusting providers or feeling understood. That might be where we then kind of take a little bit more time in that rapport building phase to really help the family feel like we're listening to them, like they're understood, and to really place that value on that relationship. Then there's intentional discussion of cultural and contextual factors. So if you're learning about issues coming up that are relevant to the family, potentially relevant to the problem that they're dealing with, it's important to directly bring those issues up in session, rather than just kind of assuming they don't have anything to do with the problem they're coming in for. So examples such as discrimination, racism, again, that acculturation, and acculturative stress. Those are just some small examples of different factors that could come up and be really important in how we're understanding what's going on, and also what different exposures or practices may look like. Also with acculturative stress, how, you know, being able to talk about that in terms of the normalizing process of there being a lot of stress in relationships when there's different values and beliefs that the kid shares versus the parents, and that process is normal even for families who all are from the US, but that even more so when we have those different levels of acculturation. And it may be that helping the kid and family member understand each other a little bit better might be an important part of treatment that wouldn't have been if you didn't ask those questions. I have a child with pretty severe social anxiety whose parents are immigrated later in life, and they have very specific ways that they handle things in terms of their accommodation and around safety. But that's very important to them because of where they immigrated from. Things were very unsafe, and they want to make sure to provide their child with the safety that they didn't have. While the child just is super embarrassed by it, thinks that their parents are different than all other parents. And those perceptions are really important to understand as a therapist, but also for the family to be able to communicate with one another. So that's then part of that treatment process that might otherwise not be. And then the process in terms of having culturally relevant materials, having handouts that are representative of the youth that you're working with, other materials, of course, in the language that your family speak, and then thinking about who's involved in treatment, whether there's other family members, siblings that might be important to be involved in treatment. And then thinking about where and how you carry out exposures. So this can be a really important piece, and similarly with like behavioral parent training, that oftentimes we think about parents maybe being resistant or hesitant to practicing things in public, but there can be lots of different reasons for this, and lots of valid reasons too, in terms of, is it safe for a parent to be in public with their child kicking and screaming? And for a lot of families of color, they're more likely to have issues with the law, with law enforcement, and a lot of kind of racial discrimination that leads to more dangerous situations. So we need to be kind of taking those things into consideration, having those open discussions with our families when planning exposure practices, rather than just focusing on the clinical utility, which is, to expand the generalizability, but we also want to think about what's important for the family in terms of their safety and their beliefs as well. So the last piece here, I think we can potentially have some conversations around this too, but it's important to think about how you might be able to, like when, what, how, and why you might integrate these kind of cultural assessment components into intake and treatment processes. And I mentioned this before, but there's not a lot of guidance on how, and the CFI hasn't been done in lots of different ways across studies. So basically, there's no right or wrong way to use it. But we do know from all of these disparities that exist, from some of the research showing that it can be beneficial in improving communication, helping parents feel understood, that it is important to be asking these questions. So thinking about what you want to use, whether it's you want to use the core CFI or the child component, or you want to integrate other questions that you think are valuable, when you might implement it, so prior to diagnostic assessment, or whether you want to weave it into questionnaires or assessments that you already have in place, or whether you want to do it after diagnostic assessment. There's kind of reasoning behind different ways of implementing it. Whether you want to use the full thing or just certain domains or questions based on kind of how a family is presenting, what you know about them, and then why you're making these decisions. So one important thing is to make sure that these decisions aren't just being made out of kind of comfort level, like what feels comfortable to ask. That was one thing that came up in our study too, was that therapists weren't as comfortable asking about questions around background and would sometimes skip those. But it wasn't because they weren't useful, therapists were just uncomfortable doing it. So we need to then again pull in what's coming from our own kind of discomfort level versus what's useful for the families in that time. And then with that, if clients are not adequately known, psychological treatments are restricted. As clients feel acknowledged and understood, they engage more openly in treatments and are more willing to disclose themselves. And with that, we will go to questions.
Great, thank you so much, Dr. Sanchez. That was wonderful. Definitely getting some great comments on how valuable this workshop is in so many ways, and I know it's extremely valuable for me personally. So we did get a couple questions that we can sort of start with, and then if there's additional questions, please feel free to send them in as we continue to go through the question and answer. We do have until 1:30. So one was, you know, you were speaking about some working with families primarily, you know, that might be from underrepresented groups or from minority groups. Any recommendations for the role of the CFI in settings in which people are primarily working with kind of your white, middle, upper middle class backgrounds?
Yeah.
Like why you're using it with them as well?
Yeah, that's a really great question, and I kind of meant to make that a larger point, so thanks for asking that, whoever did. This can be really useful in working with lots of different families, and kind of for some of the reasons that I discussed around like what culture is and how families will have different beliefs around their parenting style or the situations and contexts in which they grew up, relationships with other family members, stigma, like a lot of these things can still exist even if families aren't from racial or ethnic minority backgrounds. And it still can be really valuable in showing them that you are really understanding their perspective and then are able to kind of tailor treatment a little bit. And again, it doesn't mean that you're completely changing things, but you're able to really incorporate what's important to them. And also, for example, within psychoeducation, what are specific aspects that are happening within their own family that you can incorporate to make it more specific to their situation. So I think that there's a lot of value. I think some of the questions can be somewhat more challenging. So for example, when you're asking about what are important aspects of your background or identity, this is a place where if I'm working with a white family, I'm not going to stress racial or ethnic background, but I will include other aspects if they've maybe mentioned something to me that's important to them, or I'll just kind of expand it a bit and give examples of what other families might say in terms of belonging to church groups, political organizations, their neighborhood, sports groups, you know, kind of broaden that a little bit to really, and kind of say that, like, you know, we all have these important aspects of our background and our experiences, and what do you value most, what's most important to you.
Great, thank you. And this kind of goes along with that. How do you approach that when, you know, when a member of the family may not fully understand or accept selective mutism diagnosis, or may not believe it requires intervention due to some of these cultural beliefs about mental health? Are there things that you might incorporate into that assessment or into treatment to kind of help kind of tie that together?
Yeah, so there's a lot that we can do, and it depends a little bit on, you know, the full context and situation. I think the first part is really understanding where those disagreements are coming from. If you're working with a caregiver who is kind of on board with the type of treatment that you're doing, with the way that you're explaining selective mutism, but maybe another caregiver isn't, one piece is really being able to support and validate the caregiver you're working with, that it's really challenging to be in this position where, you know, another family member doesn't quite understand. So you're kind of supporting them in that, but then also the goal would be to be able to bring that other person into treatment, to kind of show them potentially what you're doing, to hear them out, what their own kind of explanations or experiences are. And I think an important piece is to kind of validate their understanding in a way that you're not like, okay, I get it, but this is actually how it is. You want to validate it and also ask if it's okay if you share some of your own perspectives or thoughts, but that you're not discounting what they believe. Of course, the goal being to help them understand why it's important that this child get support. And maybe if they have other perceptions on like what would be helpful, that you could potentially incorporate them. That's a really important piece too. I've had a lot of families who think that, you know, religion is really important and that this child, you know, if they were closer to God, something, they wouldn't be having these issues. And that's an area of understanding that, taking that in. How can we think about religion being an important piece or protective factor, and incorporating that while also kind of sharing what we know about selective mutism and how it's not something that a child chooses, or that's, you know, lots of kids are experiencing these types of symptoms, and explaining it how we know. But there's not really, as you can see, a straightforward answer. It's a lot about how we can both validate someone's experience as valid, because it is, and then also incorporate the knowledge that we have, and try to kind of come to a common ground. But a big piece of it is that that collaborative decision making, you bringing what you have, listening to the family, and how can we come up with something that feels like a good fit.
That's great. We had, you know, someone comment on the first question, and I think it's a really valid point. I think I had the assumption, it's just because I know who asked the question, but I think you might have had that assumption too, inherent in the first question, that the therapist is white and the patient is white. But they commented on, what if the therapist is a person of color working with white families? Are there any different recommendations that you might have based on that?
I think it would be similar in that even if it's a white therapist and a white family, there can be an assumption that like, oh, we're good, we understand each other, but oftentimes like there are so many differences, even if you have the same color skin, that it's important to always kind of acknowledge that I've had different life experiences than you have. And because of that, I want to really understand your own perspective. I think being a provider of color, working with a patient or patients that are white, there's going to be some more complexities, and potentially, you know, there could be times when a client says something that's disrespectful to the therapist, where, you know, other types of conversations may need to be had that are different or in different ways than if the therapist is white or identifies as white. But I think a important piece is that always acknowledging that the patient or the family has their own set of values and beliefs that are important and that are unique to them, and that as a therapist from a different background or from the same one, but with different experiences, you want to understand them, their perspectives and ideas as best you can. So it's kind of about, no matter what, acknowledging those differences. I think also being a white therapist, working with a family of color, is really important to point that out too, that, you know, you may have experienced discrimination or, you know, these other experiences with previous providers, experiences that I haven't had. So you want to acknowledge those differences, but also be willing to hear and understand the patient's and family's own perspectives.
Great, thank you. Yeah, that's really helpful to think through. So somebody was asking kind of what, in your experience, has been the biggest challenge you've encountered in building rapport, or kind of any particular strategies you found to be best to kind of bridge that gap if you're still struggling, even if you have types of great interviews and with these clients.
Yeah, So I'm, again, just giving my perspective or with some of the research and work that I know, but there's lots of other great perspectives and ideas out there. Biggest challenges, I really think that being persistent is important, and also knowing that you will probably make mistakes when asking more difficult questions. And a lot of us haven't had great training around how to have these types of conversations in the therapy room, and that you will probably, again, make some mistakes and it might be awkward. And that definitely happens. I've had plenty of awkward experiences with parents, and you get through it. And by asking questions, and with the cultural humility piece, like showing that curiosity and being able, like, okay, to say, I don't know this, like, can you tell me a little bit more about it? And sometimes I do have situations where parents don't want to, and that feels uncomfortable for me sometimes, that I do something wrong. But then reminding yourself, like, the point is to show that you're there and can have those conversations. And if they need something else, that's important too. There are times when families might want to work with someone that has had more similar experiences to them. And that's really valuable and important information. And if they can get that, that's really important that they do. But I think the showing that you are there, like if a family says, I don't want to talk about that, or something like that, just letting them know, like, I'm here to have that conversation. If you'd like to, if you feel comfortable, potentially even bringing it up again a little bit later, if there's a particular topic that you feel like is coming up or is important. But definitely want to highlight that it will be challenging. It is challenging to have these conversations. And that there are times that families don't fully understand or don't want to answer. The majority of the time, though, I've really found that people like being able to share their own experiences and what's come up for them. And, they don't often get the opportunity to do that in a clinical setting. And that's the majority of the experiences I've had, is families are like, oh, I've never been asked this before. I've never talked about this before. And it also makes sense why a lot of people kind of leave situations feeling misunderstood, because they don't get asked a lot of information about their own experiences.
Yeah, really good points. I mean, I think that we don't, again, this isn't, and somebody had commented on this too, just that, and hopefully that these things continue to be discussed in trainings and in new, master's programs, doctoral programs, education programs, so that there's more discussion of these types of things going forward, because I think you're right, they haven't really been trained, been in too many training programs, unfortunately. So a couple questions I'm going to kind of pull together, but kind of thinking about when you're using these types of questions with specifically with kids with selective mutism, are you using them kind of in the open-ended format? Are you switching them up to forced choice in some way to try to get more responses? And are you using them kind of, I know you had said for some cases you're using them throughout treatment, or do you recommend a particular time frame for those kids kind of in particular?
That's a really good question. And Jamie, if you have any thoughts with this too. So my initial kind of thoughts is that, so with younger kids in particular, that getting the information from the parents is a really good start, because you're able to understand a lot more about their context just from talking to the parent about these questions. We know that oftentimes for kids with selective mutism, like, answering complicated questions is going to be really hard, especially at the beginning of treatment, in which case I would say that even though we'd like to get this information as early as possible, that we might want to wait until the child is more comfortable and able to kind of graduate to answering those open-ended questions, because we're not going to really get a ton of information if we're only asking them those yes/no pieces. I also think that, like, if we have an idea that the child might be going through something that's kind of relevant to their cultural or background or identity, to kind of share information with them, read a book with them. We use a lot of that anyway about kind of, recognizing emotions, but other types of topics, dealing with racism, discrimination, things like that, or having, a different type of family, a family that's not traditional, that those types of things can be kind of brought up in easier ways. And then I think that it makes sense to wait to ask those questions, and that it might be something you're integrating into later portions of treatment when you're able to work on more of the cognitions and things like that, especially if the kid's a little bit older. But that you'll still have enough information from the family to kind of incorporate and think about within your treatment planning. Do you have any other thoughts, Jamie?
Yeah, one thought I had, I mean, I think your thoughts are spot on. I think the other thing, oftentimes, we try to really encourage the more of those verbal responses and using those open-ended questions or the forced choice questions. I mean, I think I would be careful to not necessarily go down the road of the forced choice questions, just because you don't want to kind of pigeonhole them into some particular response or make them feel like there's only these couple responses.
Exactly.
But I do wonder if this is a good time for them to be able to write something down. If you feel like this is an area that they really should be exploring, or the parents are indicating, hey, they're really struggling with this, like in addition to the books and that type of thing, it may be an area that they could write or journal about. Again, we don't often want them to be communicating with us through writing, but this may be something that's harder for them to communicate in full form. So I think there's ways, but I would definitely agree to kind of push it later until they're feeling more comfortable just in general communicating.
I think that's a great idea. I had thought about that in terms of answering some of those questions, at doing it in a written format, even though we don't typically do that. If especially it seems like it's going to be important for treatment throughout, or whether it's more of later component that when you're working on some more in-depth treatment with them, rather than just kind of the behavioral piece, and some like kind of potential identity development, like who they are, what they're proud of, how they see themselves, and that can be a really useful way, kind of an art project or something where there's not even as much talking, but a way of being able to express themselves and who they are in the world and their family. I've done that also, and it's kind of a great way for kids to be able to express the different aspects of their identities and who they are.
Yeah, and it typically leads then to that verbalization of that, because oftentimes reading it is easier, and then hopefully eventually then it can lead to that conversation. But yeah, I love the art project idea. One other question as we kind of wind down with our time, how long does it typically take to go through the core CFI? So good question.
I should have mentioned that. Great question. So it typically takes around 20 minutes. I think it can vary widely depending on the family and how much information they have to share. And I know that this is really tricky with certain, especially community behavioral health, or where you're billing for services and it needs to be a certain time. I'm in a place where I can kind of be more flexible, and I can take up more time asking these questions if I want to, and sometimes I'll take a little while longer if a family has had a lot of experiences that are important for them, because I think just kind of cutting it off sort of defeats the purpose if you're trying to help a family express these things, and then you got to cut it short. So I think that's something important to think about in terms of how to potentially incorporate it into your work, is how feasible can it be, and when might be best to use it. But typically around 20 minutes, could be a little less, could be a little more, depending on the family. Good question.
Yeah, very good question. And the supplement, about how long is that?
It's supposed to be a little bit shorter. I think that will vary widely too. With some kiddos won't have a whole lot to say, and some will have a little bit more, but typically that would be a bit shorter.
Okay,
Probably about
great.
10 minutes.
Okay. Well, thank you so much, Dr. Sanchez. This has been wonderful. We've gotten a lot of really great comments and how valuable this information is, again, because we don't seem to get too much of it. So thank you again for sharing all of this wisdom with us. Again, please be on the lookout. We will have the link to the recording as well as the slides coming out. And I think we got through all of the questions. If we didn't, we will be sending everything over to Dr. Sanchez just in case, and she will see your comments. Because I know some of you were hoping to connect with her after the webinar just by email. So she will receive those. And as Dr. Sanchez alluded to, we are going to be having some panels coming up through live webinars for bilingualism and selective mutism. One for parents, one for professionals. We're still solidifying the dates on those, so be on the lookout for those coming forward through email. So thank you for attending, and hope everybody has a great afternoon and stay safe. Thank you.
Thank you.